Dr. Alkhouri, I just love so many of the pearls that you've shared with us. Anytime I can learn about an ELF score in the Christmas season is a winner. I
Yes.
love the three S's. Great stuff. Listen, let me just pivot back to Professor Shira. Your talk really inspired me thinking about the importance of including a dietitian in that primary care team. And there's so many family physicians and primary care practitioners across Canada that do not have access to a dietitian and nutritionist. So, you presented the evidence around three diets. If there's one thing, one diet piece of information that a family physician can give to a patient, what would it be in a short visit?
Okay, so I would go for Mediterranean diet, but I would emphasize mostly the importance of reduction of sugar consumption, high sugar food, and sugar beverages. That's the first step that I do with patients, the most significant one. And then you can discuss a little bit about saturated fat and processed meat. But generally, I recommend minimally processed food like Mediterranean diet, and most importantly, reduction of sugar.
And really like that simple messaging. And of course, we're used to talking about the Mediterranean diet for our patients with hypertension, our patients with heart disease. So it's a nice message and a simple one at that. Dr. Alkhouri, so question, and just a reminder for our Canadian primary care group, Resmetirom is not available in Canada. So if we were looking at something off-label, we're talking about semaglutide. So a question that I would have for you, and I know we don't have time to get into mechanistic approaches, but do you think that the improvement that you're seeing in patients with fatty liver from semaglutide is from the weight loss, or do you think that there's something about the GLP pathway that favors liver health?
Yeah, I mean, as far as we know, there are no GLP-1 receptors in the liver, in the hepatocytes or other liver cells. So we do believe that, the benefit is mediated by weight loss. What we are eagerly waiting to see in the Essence trial is the response data based on the percentage weight loss. We've known from lifestyle interventions that losing 10% of your total body weight has been associated with MASH resolution and fibrosis improvement in up to 45% of patients in one study. So I think, weight loss is a solid mechanism to induce improvement in MASH and fibrosis improvement. I think in diabetics, obviously, controlling diabetes may also contribute to this. And, the cardiovascular benefits also, we should always keep this in mind that these patients, the number one cause of dying in patients with MASLD is cardiovascular disease. And the fact that semaglutide, and now we have data with tirzepatide, can improve cardiovascular outcomes in diabetics, but also in obese based on the SELECT trial, should also influence our decision on how to treat. So multiple reasons, but again, we can't also just focus on hepatic efficacy endpoints. We need to look at the entire picture.
Yeah, and actually that comment really riffs to Gabriella's comment in the chat that sort of talks about MASH and MASLD as being part of the metabolic syndrome and thinking about diabetes prevention. There's themes that go through all of this. Shira, I was told by my mother to always give the last word to a dietitian, so I'm going to give you the last question here. And it was a provocative one, part comment, part question by Miriam online, where she talked about referenced patients with disordered eating, binge eating disorder, bulimia nervosa, and suggested that decisions or advice around diet you may want to think more Mediterranean diet than restrictive diets like intermittent fasting. Your comments on that?
I completely agree with that, and it shows the importance of personally tailored treatment, and how much the human contact is important. Many patients now go to digital kind of treatment, and I support digital treatment, but I think it should be followed with a human in-person treatment. And this is exactly a good example that we should have a long discussion with the patient and see whether there are issues of disordered eating, whether they choose the right diet for them. I saw a comment about intermittent fasting. It's not for everyone. There is a study about the increased mortality. I don't agree with that much. I think it's an observational study, which is prone to a lot of bias, but put it on the side. We need to be very careful with the diets we choose. We need to know the patients good enough and to choose the right diet for them.
And your comment about knowing the patients is a great segue to our next session. So thank you so much for all the pearls and all the practical tips that you've given us to help manage these patients. Thanks very much, guys.